welcome. My name's Jacob. I'm a final year medical student at Lancaster Medical School. Welcome to part 7 of this cardiology series, where today we're going to be doing an introduction to ECG interpretation. And we're also going to be going over some general cardiac and ECG principles too. Okay, so with that being said, let's get straight into the video. Right, so first of all, we need to talk about placement of the electrodes. And the electrodes are essentially little pads which serve to conduct the electrical activity of the heart. So we have our limb electrodes and we also have our chest electrodes too. Sometimes chest and precordial, them words can be used interchangeably. So let's talk about our limb electrodes first. So we have electrodes placed on the left arm, left leg, and also on the right leg. The electrode on the right leg typically serves as the neutral electrode. So the purpose of the neutral electrode is that it provides a pathway for unbalanced electrical charge, just as a ground would. Okay. And essentially, when you have these limb electrodes, you want to place them on a bony prominence. So, for example, the left leg, the medial malleolus or lateral malleolus could serve as a bony prominence. And then in terms of our chest electrodes, we have V1 to start off with, which is this red one here, which is at the fourth intercostal space, right parasternal. We have V2, which is the fourth intercostal space, left parasternal. I'm going to come back to V3 in a second, because we have V4, which is the fifth intercostal space, left midclavicular line. It's an important anatomical line and an important anatomical landmark on the chest, because we know at this point it's best for auscultation of mitral murmurs. And then if we go back to V3 for a second, we know that that's going to be midway between V2 and V4. And then we have V5, which is at the fifth intercostal space, left anterior axillary line, the line here, the left anterior axillary line isn't drawn on this diagram, but where I'm putting my laser pointer, this is where you'd imagine that it'd be. And then V6 is at the fifth intercostal space, left mid axillary line. So we can see V6 here in the purple. Okay. And then essentially all of these electrodes, so we have 10 electrodes in total, help to produce 12 heart leads. And essentially leads are just different views of the heart, which we're going to talk about in more detail. So these are split into the bipolar limb leads. Bipolar because they measure the electrical activity between two poles, so between two electrodes. We have a negative and a positive pole. I'm going to discuss that in more detail as well. And they are leads 1, 2, and 3. We also have our unipolar, sometimes called augmented limb leads, and then they only require one pole, one electrode, and they are AVL, AVR, and AVF. And then we have our precordial leads, otherwise known as our chest leads, and they go V1 to V6. So in total, we therefore have 12 views of the heart, despite having 10 electrodes. Okay, guys. So what I want you to remember is that because this is a 12-lead ECG, we have 12 different views of the heart, despite having 10 electrodes. Okay, so we're going to talk about the views which the limb leads provide first, and the limb leads view the heart in a vertical plane. So let's just go over to this diagram first. So here we have an electrode. We have another electrode. This electrode is going to be our negative pole, otherwise known as the reference point. And this electrode is going to serve as our positive pole, otherwise known as the point of view. And then this essentially here is the line of sight. But in terms of our point of view, which is represented by this black arrow, this is the direction, the specific direction in which we are viewing or looking at the heart. Okay, and then we have this key at the bottom. The solid red arrow represents the bipolar lead, the leads, and then the dotted red arrow represents the unipolar leads. Okay, so let's talk about the bipolar leads first. The bipolar, because it's bi within that word, measure the the voltage or the electrical activity between two limb electrodes. Okay, so we have our negative pole, our positive pole. This is the electrode on our right arm and our left arm. And lead 1 measures the voltage between the right arm and the left arm. Okay, and this allows a view of the heart from the left. Because if we look here at this diagram, this is our point of view. So this eye is going to be here. So we're looking at the heart from the left. Okay, so that provides a view of the left side of the heart. Again, we have our negative pole, we have our positive pole. And lead 2 is going to measure the voltage between the electrode on the right arm and the left leg. Again, negative pole, positive pole. And lead 3 is going to measure the voltage between the left arm and the left leg. Okay. So next we need to talk about the unipolar leads. So uni meaning one. So one limb electrode is going to serve as the positive pole. All right. So that's an important concept to understand. So either the electrode on the right arm, on the left arm, or on the left leg is going to serve as the positive pole. I want you to remember that. It's not actually shown on this diagram, but I want you to remember it. So that this one, this one, or this one is going to serve as the positive pole. Okay. And the negative pole is going to be the average of the inputs from the other limb electrodes. Okay. So you'll understand that more in a second. So we have our negative pole here, which is the average of the inputs from these two electrodes. Okay. And then remembering that the electrode on the right arm is going to serve as the positive pole. So we're measuring the voltage between the positive pole on the right arm and the average of the inputs between these two electrodes here. Okay, and this is the voltage recorded is represented by this dotted line. And that's going to basically produce the lead known as AVR, which looks at the upper right side of the heart. And you can apply the same principle all the time because look, the electrode on the right arm is representing the positive pole. Therefore, the point of view is looking in this direction if I drew an arrow. So we're looking at the upper right side of the heart. Again, we have our negative pole here. This is the voltage which is being measured between the negative and the positive pole, and this is going to produce the lead AVL. AVL looks at the upper left side of the heart. Again, we have our negative pole. The electrode on the left leg is representing the positive pole. The voltage between the two poles is being measured, and this is going to produce our lead, otherwise known as our view, AVF. And this is going to look at the inferior surface of the heart. So look, our point of view is going up in this direction. So we're looking at this inferior surface of the heart. So I know that can be quite a tricky concept to get your head around, but hopefully that makes sense. That makes much more sense than it did originally. Okay. Okay. So now let's talk about the views which the precordial or chest leads provide. Okay, and it's important to remember that the chest leads, I'm going to call them, view the heart in a horizontal plane, illustrated by this diagram. Okay, and essentially our negative pole is basically it's an average of the inputs from the three limb electrodes. So remember we had our limb electrodes. We had the electrode on the right arm, which would be up here. We had the electrode on the left arm, and then we had our electrode on the left leg, remembering that the electrode on the right leg is the ground. So remember, so left leg electrode, right arm electrode, and left arm electrode. Essentially, the negative pole is an average of the inputs from these three. electrodes. Okay, and the chest electrodes, so um, related to the positions V1 all the way through to V6, represent the positive poles. Okay, and these are all unipolar leads. It's worth mentioning. Okay, so V1 and V2 allow a view of the ventricular septum and the right ventricle. And we can apply the same principle. So if we look at the positive pole here, this is where we have our point of view. So we're going to be looking in this direction if I was to draw an arrow. So therefore, we're going to have a good view of the ventricular septum and the right ventricle. Okay. V3 and V4 allow a view of the anterior wall of the left ventricle, and then V5 and V6 allow a view of the lateral wall of the left ventricle and the apex of the heart. Um, when you when you have precordial or chest electrodes, you can also have posterior electrodes too. So you can have a V7, V8, and V9, and they provide a view of the posterior wall of the left ventricle. And this is something I intend to go into more detail in future videos. Okay, and then we can see that in leads V1, V2, and V3, the QRS all has a negative deflection, so it's pointing downwards. And then in V4, V5, and V6, the QRS has a positive deflection because the QRS is pointing upwards. And we're going to talk about more as to the reasons why this happens. So next, it's important that we do a review of the cardiac conduction system. Okay. So first of all, the SA node, known as the pacemaker, generates an action potential. Yes, so the SA node's here. It's located in the right atrium. And the impulse spreads across the atria via Bachmann's bundle, then causing contraction. Okay, so we can see it on this diagram. It links with the flow chart on the left. And the SA node is influenced by the sympathetic and parasympathetic nervous systems. And in terms of its arterial supply, it's supplied by the sinus node artery, which is a branch of the right coronary artery. Okay. And then the impulse is delayed at the atrioventricular node, the AV node, for 60 to 120 milliseconds. Okay. And essentially, this allows the ventricles to fill with blood and prevents premature ventricular contraction. Okay, and the AV node is supplied by the AV nodal artery, which is a branch of the posterior intraventricular artery, which is normally a branch of the right coronary artery. There's a lot of anatomical vessel variation. Okay. And then the impulse is conducted to the bundle of His down the interventricular septum. Okay. And the bundle of His also splits into right and left bundle branches. The left bundle branch has an anterior and posterior division. That's important when we talk about bundle branch blocks, because you can have an anterior fascicular block or a posterior fascicular block. The Purkinje fibers transmit signals across the ventricles. Okay, represented by the number 5. So we have our Purkinje fibers transmitting the impulse across the ventricles. The Purkinje fibers also conduct the electrical impulse the fastest. They're located within the subendocardium, and they permit coordinated contraction via gap junctions. So gap junctions are channels which allow movement of ions between cells. We have something formed called a syncytium, so a lake, basically permitted by these gap junctions, so we have coordinated contraction. And I've already mentioned it because maybe he's got a bit excited, but 6 represents ventricular contraction. Yeah, so first of all, I'd like to direct your attention to this diagram in the top left-hand corner. And it's going to look slightly familiar because remember we have our two electrodes here. This is going to be our negative pole, otherwise known as the reference point. We have our positive pole, known as the point of view, and then we have our connecting line connecting the two poles. Okay, and we're going to take this to be lead 2 for this example. Just before we talk about this ECG trace and what some of these terms mean in more detail, I've just got some definitions. So we know that a wave is a deflection. So a deflection in the ECG line due to a change in the electrical activity of the heart. Segment is a line between two waves, and an interval is a period including a segment in one or more waves. And here we have our P wave, which is a positive deflection, and this represents atrial depolarization. We have our QRS complex, which represents ventricular depolarization. And then we have our T wave, which is also a positive deflection, and this is going to represent ventricular repolarization. Okay. We have our PR interval, which is between here and here, and this is the time between atrial and ventricular depolarization. We have our ST segment, which is very important. So this is the time between the end of ventricular depolarization and the start of ventricular repolarization. And the reason why the line, the ECG line is flat in this place for this period of time is that because there's no difference in the voltage, so there's no potential difference across the cardiomyocytes at this point in the conduction cycle. Okay, and then we have our QT interval, which is the total time of ventricular depolarization and repolarization. We also have a U wave here, and the origin of the U wave is still fairly unknown. Okay, so here we have two diagrams. We have one diagram representing the atria, and then another diagram representing the ventricles. And essentially what these diagrams are, it's this grey area here is representing muscle tissue in a salt solution, and we have an electrode connected to each side. So we have a negative electrode here and a positive electrode. And essentially we're going to stimulate this left side to produce an electrical impulse, otherwise known as an action potential. And this is basically representing the function of the sinoatrial node. The grey area with the ions, with the negative and positive ions, is essentially the extracellular space, or within the body it'd be known as the extracellular fluid. Okay. So if we look at the atria first, we know that depolarization towards a positive electrode gives a positive deflection, and I can show you from the diagram how this is represented. So when it's depolarized towards the positive electrode, we're going to have a positive deflection. Okay, but when we have repolarization towards a positive electrode, this is going to be represented by a negative deflection. So if you look here, there's going to be a negative deflection. And in the atria in particular, because repolarization happens in the same direction as depolarization, hence why you have that negative deflection. Okay. But when we look at the ventricles in terms of their repolarization, the ventricles repolarize from the apex upwards. Okay, so ventricular repolarization is in the opposite direction to ventricular depolarization. Okay, and hence this is why during ventricular depolarization we'll have a positive deflection, and also during ventricular repolarization we'll have a positive deflection too. And we know that positive deflection seen in ventricular repolarization is the T wave. Okay, so that's essentially why um, the T wave's produced and has that positive deflection. Okay, so let's talk about um, the ECG paper itself. Okay, so we have the paper speed, which is roughly 25 millimeters per second. In terms of the calibration, 1 millivolt is equal to 1 centimeter. We have the rhythm strip, which is usually from lead 2, and this is a prolonged 10-second recording. It's very useful for working out the rhythm and also the rate. And then in terms of the ECG, the grid paper, we have small squares and we also have large squares. So the small squares you can see here, I can just about fit my laser pointer in one of the small squares. They're horizontally 1 millimeter, which represents 0.04 seconds, and then vertically they're 1 millimeter too, which represents 0.1 millivolts. And then we have our large squares, which horizontally are 5 millimeters across, and that represents 0.2 seconds, which is the same as 5 times 0.04. And then vertically, they're also 5 millimeters, which represents 0.5 millivolts. And the amplitude of the electrical activity. Amplitude is the same height. These are other clinical details which you want to be aware of when you're recording ECGs. Very important for a hospital setting. Just first of all, we have a general definition of an ECG, and we know that it's a recording of the electrical activity of the heart captured by the external electrodes and transcribed, so written onto graph paper as the ECG leads. Remember, the leads are the different views of the heart. We want to be aware of the patient's age, things for the history. Do they have any chest pain, previous heart attacks known as MIs, histories of COPD or hypertension, high blood pressure. Have they been having any palpitations? Identification information, so a name, the date, the time of recording, all very, very important details. Okay, so when we have a systematic approach to ECG interpretation, there's a certain structure that we should follow. So first of all, we want to assess the rhythm. Next, we want to assess the rate. We want to assess for any axis deviation. And then finally, we want to look at waves, segments, and intervals. All right, so let's talk about how to interpret the ECG rhythm. So we want to observe the frequency and regularity of the P waves and QRS complexes. We also want to look at the relationship between the two. We want to use the 10-second rhythm strip, which remember is lead 2. We've got a normal rhythm strip at the bottom here, which I'm going to come to in a second. Remember, so sinus rhythm is the physiological heart rhythm and age-appropriate heart rate set out by the sinoatrial node. And simply put, sinus rhythm, if you're asked by one of the doctors on placement, for example, we know that it's a P wave followed by QRS complex. Sinus rhythm also has a normal PR interval. PR intervals can be prolonged in people such as athletes. They might have an aspect of first degree heart block, but typically there'll be a normal PR interval. The P waves will also be positive in leads 2, 3, and AVF, negative in AVR, and it's important just to keep an eye out for any P wave abnormalities, whether that's a change in the width, the morphology, or the height of the P waves. Okay. And when we talk about rhythms, we can have a regular rhythm. We can have a regularly irregular rhythm, or a rhythm can be irregularly irregular. Okay. And I'll have this rhythm strip at the bottom here, and we have 3 red lines. And essentially, what you can do is you can move these red lines along the rhythm strip to line up with the R waves, the tip of the QRS complex, to determine if there is an irregularity to the rhythm. Okay. And then here, this is an example of sinus rhythm because we have a P wave um, followed by a QRS complex. This rhythm here is regularly irregular. It's such a mouthful saying that. And this particular rhythm is that of a supraventricular tachycardia. And if you notice, there aren't any P waves in particular. This also gets me onto the topic of talking about pseudo R waves and things like that, what you might see in SVTs. But for now, um, just remember that an SVT is regularly irregular. Atrial flutter is also has a regularly irregular rhythm. And then the classic arrhythmia, which has an irregular rhythm, is atrial fibrillation. Okay, so look, if you look here, you can see that there's lots of different, the space between um, the RR intervals is very variable. It's not consistent, and also in F, it's important that we don't really have any. There's no discernible P waves. Okay. Let's look at the rate now. So we know that a normal heart rate is roughly between 60 to 100 beats per minute. Tachycardia, a fast heart rate, is greater than 100 beats per minute, and bradycardia, a slow heart rate, is less than 60 beats per minute. Okay, so let's talk about the methods of interpretation. Before we do so, you might be aware that kind of a maximum heart rate is roughly 220 minus your age. Yeah, then we want to determine if the patient has a normal rate or if they're tachycardic or bradycardic. If they have a regular QRS rhythm, that's why it's important to work out the rhythm first, whether it's regular or irregular. We can do 300 divided by the number of large boxes between two successive QRS complexes, so the RR intervals. So if we look here, for example, between this R wave and this R wave, we have 1, 2, 3, 4. We have 4 large boxes, therefore the rate is going to be 300 divided by 4, which is roughly about 75, I think. And then if we have an irregular QRS rhythm, so for example in atrial fibrillation, we can do 6 times the total number of QRS complexes in the rhythm strip. So again, that's typically lead 2. So if we count the number of QRS complexes, we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Times that by 6, which is, that 70-ish. I think it's about 72. Okay. And the methods what I've just mentioned of determining ventricular rate, atrial rate can also be calculated by doing the same for the P waves. And atrial fibrillation is a good example where atrial rate and ventricular rate can significantly vary because atrial rate can be anywhere greater than 300 beats per minute, and the corresponding ventricular rate can either be it can be slow because you can have slow F, or it can be very, very fast, typically in young people. And I mentioned this in my video about atrial fibrillation, where that's called a rapid ventricular response, where we tend to have a high ventricular rate in response to that, a high atrial rate. So that AF is a good example of reasons why you might want to calculate the atrial rate too. Although that might actually be difficult because on the ECG trace itself, feature of AF is that there aren't any discernible P waves, so that I'm sure there'll be another method of doing that. Okay, so now let's talk about axis deviation. So what is the cardiac axis? So the cardiac axis represents the mean direction of ventricular depolarization in a frontal plane. Okay, so in a frontal plane. A normal cardiac axis is between -30 to +90 degrees. And my personal favorite method to determine if there's any axis deviation, or if the axis is normal, is the leads 1 and AVF method. Other methods include the isoelectric QRS complex method, and I suggest you have a look at this in your own time. I personally prefer the leads 1 and AVF method. So what you want to do is you want to determine the deflection of the QRS complexes. In other words, which way does the R wave point of R wave of the QRS complex point? Does it point upwards, or does it point downwards? Upwards representing a positive deflection, downwards representing a negative deflection. Okay, so if there's positive deflection in both leads 1 and AVF, that suggests that there's no axis deviation. That's a normal cardiac axis. If there's positive deflection in lead 1 and negative deflection in AVF, that suggests that there's left axis deviation. If there's negative deflection in lead 1 and positive deflection in AVF, that suggests that there's right axis deviation. And if there's negative deflection in both leads 1 and AVF, that suggests that there's some extreme right axis deviation. That can be seen typically in quite severe right ventricular hypertrophy. Okay, so let's look at an example. So we're going to use the leads 1 and AVF method. We can see that there is negative deflection of the QRS complexes in lead 1, and there's positive deflection of the QRS complex in AVF. Therefore, we have right axis deviation. Okay, so this is an example of right axis deviation. There's various causes of right axis deviation, and left axis deviation, etc. And we're going to detail them in future videos, as this is an introductory video. But generally some causes of right axis deviation, right ventricular hypertrophy, a right bundle branch block, and you can have right ventricular strain, so strain on the right ventricle due to lung pathology such as pulmonary embolism, COPD, pulmonary hypertension, or stenosis of the pulmonary valve. Even arrhythmogenic conditions such as Wolff-Parkinson-White syndrome, etc. So this is to summarize. This is an example of right axis deviation. Okay, and then finally, we're going to come to waves, segments, and intervals. So we have P waves, where you want to look at the height, the width, and the morphology, otherwise known as the shape. The QRS morphology. Okay, so are all the QRS complexes the same height? In something called cardiac tamponade, you can have a phenomenon called electrical alternance. So all the QRS complexes are kind of varying in height. Also want to look at the width too. You might have increased width in something like a bundle branch block. You want to look at the T waves, the height, the width, are they inverted? T wave inversion can be an early sign of ischemia. We want to look at the PR intervals. Are they prolonged? That's more when we're looking at heart block in particular. The ST segments, are they depressed, like in a non-ST elevation MI, or are they elevated in an ST elevation MI? And we can also look at the QT interval as well. Is it prolonged or shortened? And this can be due to various electrolyte abnormalities and even drugs, particularly antibiotics. And this is very important to be aware of in clinical practice. So in terms of the introduction, that's everything that I'd like to cover today. I'm going to mention that I will be making separate videos on each of these in more detail. So P waves, the QRS complexes, T waves, PR interval. You get the gist. Okay, so we're going to be going over these in more detail, and when we cover these in relation to specific disease processes, it'll really ingrain all of this detail in your head. Okay, so like I said, this is an introduction. We're going to be covering all of these little subtopics in more detail. So I just want to say thank you for tuning in. Really appreciate all the support. And yeah, keep your eyes peeled for the next video on P-wave interpretation. Take care, and I'll see you then.